My name is, Good morning, everyone. My name is Sweta Pasala. Thank you for attending our George Vetrovec Grand Rounds lecture. The George Vetrovec Cardiology Symposium was founded in 2015 by faculty and friends on the occasion of his retirement from VTU. Their generosity was inspired by the goal of founding an annual symposium or lecture for the Division of Cardiology. Dr. Vetrovec earned his BA and MD from the University of Virginia. He went on to complete his internal medicine and cardiology training at VCU's MCV Medical Campus. He then joined the faculty and during his tenure served as chairman of cardiology for 18 years. And he also served as director of the Cardiac Catheterization Laboratory for 38 years and as associate chairman of medicine for clinical affairs for 23 years. Dr. Vetrovec's career focused on improving the management of coronary artery disease, particularly related to coronary interventional techniques. And Dr. Vetrovec and Dr. Michael Pauley actually performed the first coronary balloon angioplasty at VCU in 1979. 2 years after the first procedure was performed in the world, following training by the inventor, Dr. Andreas Gertznig in Zurich, Switzerland. Following his retirement from clinical practice in 2015, Dr. Vetrovec continues as professor emeritus and serves as the MCV Foundation Board member, the Pauley Heart Center Advisory Board member, and the MCV Physicians Board member as well. In addition, Dr. Vetrovec is involved with many committees, including the ACC committee and editorial leadership, and participates in the FDA New Cardiovascular Devices panel and serves as a medical consultant. And now I am pleased to introduce to you our speaker, Dr. Samir Kapadia. Dr. Kapadia is the chairman of the Robert and Susan Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic. He is also professor of medicine at the Cleveland Clinic Lerner College of Medicine. Dr. Kapadia's clinical interests include percutaneous treatment for valvular disease, TAVR, mitral clip, complex coronary interventions, ASD and PFO closure, carotid interventions, and peripheral interventions. Dr. Kapadia has performed over 1,000 TAVR procedures and thousands of other cardiovascular procedures throughout his career and has published more than 300 articles and abstracts in scientific journals. Dr. Kapadia has received his medical degree with honors from the NHL Municipal Medical College in Gujarat, India. He completed his internal medicine and residency at Baylor College of Medicine and completed fellowships in cardiology and interventional cardiology at Cleveland Clinic in Cleveland, Ohio. Dr. Kapadia was appointed to Cleveland Clinic in 2003 as a staff interventional cardiologist, and prior to his appointment at Cleveland Clinic, he had an academic appointment to the Department of Medicine at the University of Washington in Seattle. We're very grateful for Dr. Kapadia's expertise in the topic of the percutaneous therapies for mitral and tricuspid valve disease, and we look forward to hearing from him. At the end of this lecture, we will leave time for questions. Please submit them via the chat function on Zoom as you have them during the talk. We are pleased to offer both CME and MOC credit for our lecture series today. And to claim credit, please text the code shown at the beginning and at the end of the presentation to 804-625-4041. If you have any questions or to log on to your Cloud CME account, please visit vcu.cloud/cme.com or contact Shannon Winston. I will now turn it over to Dr. Samir Kapadia.
Thank you very much, Shweta, and it is such an honor, Dr. Vetrovec, to see you still so active, and it is a great pleasure to be part of this incredible lecture symposium. So thank you again for inviting me, and it is a great pleasure and honor for me to be part of this and also staying connected with you. So today, what we are going to try to do was to cover One second, I'm trying to move this slide forward. Yeah. So we will talk about the current status of mitral and tricuspid valve disease. Uh, so I start with a case so that just gives a little perspective of what is happening in the world. So this is a 43-year-old gentleman who has radiation heart disease, and he presented first in 2012 to Cleveland Clinic. The reason why he came was that he had a thymectomy done in the past. He had severe left main and ostial right coronary artery disease and severe aortic stenosis because of radiation. And he had moderate mitral valve disease. He was in Portland, and they did try open heart surgery. And when they opened the chest, they found severe fibrosis. So they closed the chest. And since I was in Washington, and I had a lot of friends in Portland and Washington, they called me and they said that, he's a wonderful gentleman. Can you help? So now this is talking in 2012. So the TAVR was, we started in 2006, but it was still relatively new in 2012. So what we end up doing is we stent the left main and the right coronary artery. We protect it because of these, fear that the stent will or the balloon will interfere with the stents. And so we just want to make sure that we can post-dilate it in case there is a problem. And this is the first generation valve. So I don't know if you have seen this valve, but this is an older generation valve. And we put the valve. It's done under general anesthesia at that time in 2012. And then the patient, because of radiation heart disease and just the pacing and valve deployment, had a little hemodynamic instability. And as you can see, we put him on briefly on ECMO. And then we do a little aortogram. And as you can see with the aortogram, there is some aortic regurgitation. But at that time, it was thought that this is okay to leave this kind of aortic regurgitation. And especially when patient was on ECMO, there's a retrograde flow. So we left it like this. Patient did wonderfully. He could climb the mountains. He was doing great. I saw him every year. And then the COVID came and he could not come. And then he says that he's getting very short of breath. So in 2020, he called me, and then he came back in 21. At that time, as we have known that he had moderate PVL, but he was very symptomatic. So what we found is the aortic valve was not too bad. His mean gradient was 30, as you see there. So mean gradient is 30. His mitral valve, however, is in a terrible shape. So his mitral valve has a mean gradient of 20. So this is the mitral valve gradient, and it looks like an aortic gradient. So here you can see that the aortic valve has a gradient, but the mitral valve has a serious gradient. And there is some aortic regurgitation, more than some, but there was some aortic regurgitation. And if you look at the valve and the calcium distribution, there is a fair amount of calcium in the mitral annulus. So we usually do this kind of an assessment. So in systole, how much is the LVOT area? And it turned out that his LVOT area in the simulation was pretty good. So we thought that we could put a mitral valve in the MAC, and we can treat the aortic valve. Normally, when you do the aortic in the mitral valve, we like to do the aortic valve first, because if you put a balloon expandable valve, the mitral valve will get affected. So here we put a new valve with the aortic valve involved. And now it is an S3 valve in the first generation aortic valve. As we knew that his coronary arteries were high, but there was a clear gap because, when we sized it in 2012, we sized it with the echocardiograms and not with the CAT scan. So there was a undersized valve. We could not put a larger valve. We post-dilated it and everything else, but still, as you can see, there is a distance. Nowadays we call a dead space between the two valves, and there is a paravalvular leak. So we close the paravalvular leak with a plug, and then we put a new valve, mitral valve, in place. So this is the paravalvular leak is closed, and then we put a new mitral valve with valve in valve. And now there is no aortic regurgitation. Patient did exceedingly well. After the procedure, his mean gradient was 8, and aortic mean gradient was also low. We did write it not so much because the idea is that you can do a mitral valve replacement with valve in annular valve in MAC and the aortic valve replacement, and when we discharge the patient the next day. So it's a big step forward, because if you consider radiation heart disease patient who could not even be operated in the first place, uh, he had little kids. Both of them are in college now, and he's so happy. So this is an unbelievable uh, journey for medical side. If you look at the mitral annular calcification, uh, and MAC related mitral annular calcification. This problem has been recognized as a common problem. Most commonly, it is the posterior annular calcification, and it is a difficult problem for surgery as well. So if you go to the OR and look at this mitral annulus, it is calcified and it reaches up to the circumflex artery many times. It is deeply invasive into the trigons, so you have to sometimes remove the aortic valve and then create the annular planes in surgery. So AV groove injury, left circumflex injury are an important complication, and it is associated with stroke and then higher paravalvular leaks after surgery. Many years ago now, I think 10 years almost, we wrote this paper in Circulation to say that this is an unmet need for percutaneous intervention, because at that time there were not that many people doing mitral valve in MAC or something like that. So this was recognized as a problem. And if you look at the literature for surgery, as you can see, the surgery with MAC related mitral valve problem, the numbers are extremely small. When you see of course, mild MAC related surgery is done by a lot of people, but severe MAC causing mitral stenosis, that kind of patients are not commonly treated with surgery. Then we did this registry of TMVR in MAC in the global registry. Again, 100 patients. It's not a large registry, but there's a 50% mortality at 1 year. So it is not a simple procedure to do. And then if we compare it to mitral valve in valve or valve in ring, the valve in MAC has a very high mortality in this particular series. This is a common knowledge. However, if you look at so we also tried, and this is one another method to say that we can do a hybrid procedure, in the sense that we can remove some of the mitral valve, create a little bit of a pad on the on the transcatheter aortic valve, uh, make it such that we can deliver it at the time of surgery. And so, there's a lot of different techniques for this, to say how we can suture it to the leaflet or to the left atrium, and then deploy it such that we can prevent the paravalvular leak. And if there is paravalvular leak, we can actually close it at the time of surgery. So this hybrid approach has also been done. This is another important advancement that we call it a cleave procedure. I think because of the Cleveland, we are calling it a cleave procedure. This is a procedure that we designed to say that instead of deploying the mitral valve in the annulus, we perforate the anterior mitral leaflet. We perforate the anterior mitral leaflet and then deploy the valve. As you can see here, it is in the anterior mitral leaflet, and then we deploy the valve in the anterior mitral leaflet. So when you expand the valve in the anterior mitral leaflet, there is no anterior mitral leaflet to cause LVOT obstruction, and it moves, it deploys the valve fine. So there is a lampoon procedure. There are other things, but this particular procedure is, in our experience, better, because it can potentially remove the anterior mitral leaflet, and it is somewhat easier in many situations. So again, mitral valve in MAC is still evolving. So you can do lampoon, alcohol septal ablation, anterior mitral leaflet perforation. And of course, there are a lot of different valves that have been also tested for M3, Tendyne, Cephea. And as I said, hybrid approach is possible. With that, I'll move to the mitral regurgitation. So mitral regurgitation, this is the classic Carpentier classification. It's a normal leaflet motion, excessive, restricted, and restricted motion in systole and diastole. So 3B and 3A. And if you look at the more current way of describing this is primary or secondary MR. And if you look at the primary MR, then it can be leaflet perforation or myxomatous disease or rheumatic heart disease, and they can be in Carpentier's classification 1, 2, or 3A. And secondary mitral regurgitation, which can be Carpentier 1, where there is annular dilatation with atrial and ventricular enlargement, or you can also have 3B, which is a more classic one, where you have a restriction of the atrial, restriction of the leaflet because of the atrial and ventricular enlargement. So this, and then of course there are mixed versions. So I just want to show you one case, and then we discuss some data. So this is a primary MR patient. So this is a patient who is an 80-year-old patient with mitral valve prolapse and NASH cirrhosis. So of course, patient is high risk for surgery. Creatinine is normal, coronaries are normal, EF is normal. And if you look at this patient, so the anterior mitral leaflet is problematic. So anterior mitral leaflet is coming backwards. So there is a flail anterior mitral leaflet. And when the anterior mitral leaflet is flail, in surgery, this is a challenge because there is a severe prolapse or flail of the A3, so the medial side of the anterior leaflet. And what happens with surgery is that most of the time you would say that you would do mitral valve replacement for the anterior mitral leaflet in an 80-year-old patient. Or you can, of course, do percutaneous mitral valves. These are some of the things that we do, including clinic exam, 3, Tendyne, Cephea, twist. Or we can do MitraClip or Pascal. It is so simple these days to do a edge-to-edge repair with either MitraClip or Pascal. This particular patient, we use the MitraClip. As you can see, when we do a transeptal puncture, this is very important. So in the past, we did the transeptal puncture just using a 2D images, so like a biplane imaging. Here you would think that we are posterior from the aorta and we are in the middle of this thing, but see this particular area of the fossa is fairly anterior to the mitral valve. So this is not a good site for puncture because you will have an aorta hugging puncture. So you want to puncture a little bit further down on the septum. So we move it further down and then we puncture. So then we are on top of the mitral valve. This is very important thing that we learned. And then the imaging is so beautiful. So you can see that the MitraClip is open. We are aligning the MitraClip. This has changed everything we do is the 3D MPRs, multiplanar reconstructions in the 3D that we can do. And we can see the leaflet. There is no rush to do this procedure. We can see that the MitraClip is now aligned properly. The orientation is correct. The grippers are down. They are bouncing, as you can see. So this is a fairly simple, straightforward procedure if the imaging is good. And this is the key thing I tell people, that if we can see, we can usually do a good job of intervention. Here, we can stabilize the flailing leaflet of the A3, and there is hardly any mitral regurgitation. There's slight mitral regurgitation in the middle of the valve. So this particular therapy, edge-to-edge repair for primary mitral regurgitation, was approved by the FDA without randomized data. So we did not have randomized trial for this particular purpose. The Everest trial that included these patients was, it had some patients with primary MR. The reason how this got approved was to say that the patients before and after the clipping, there was less hospital admissions, but there was no randomized data with surgery. However, this therapy has been super helpful. So here you can see from the ventricular side, before and after, you can see that the patient has a severe MR, now no, not much MR. And more importantly, just seeing is not enough. So you want to feel it. So I say that, you measure the LA pressure. So we always measure the LA pressure. So the V waves are decreased. And we wrote a recent paper, I think it's not yet published, to say that the V prime, we call it, meaning that from the LA pressure mean to the top of the LA pressure. So here it would be, say, roughly 20 to about 60. So 40 millimeter V prime, and that V prime is now 20 to 30, so 20 to 20. So it's about 15 millimeters. So this is what is very important to characterize that what is the hemodynamic benefit of mitral. And of course, we can check the mitral gradient. And in this particular case, there's 4 or 5 millimeter mitral gradient. So you would consider to stop at that point. Now, there are two important randomized trials ongoing. As I said, that there is no randomized trial with surgery. So there is a primary trial and repair MR trial. We can discuss this at length, but I think in the interest of time, I don't want to go into details, but I'm happy to answer questions. So the primary MR is a superiority trial by CTSN, all comers, more than 65 years of age. And repair MR is a non-inferiority trial sponsored by Abbott. And this particular trial is intermediate risk patients with primary MR who are randomized to surgery. Both are randomized trials, and both have slightly different endpoints. And so this is an important academic exercise to say that how we can design the trials and what are the ethics and intentions for these trials. But these two trials are ongoing and very important for the future literature. Then we move to the secondary MR. So secondary MR is also very important. So secondary MR, this is a nice paper by Dr. Pat O'Gara in New England Journal to say that what is a secondary MR is. A secondary MR is a disease of left ventricle and left atrium. I say it can be and or in the sense that most of the time when you have a disease of the left ventricle, you also have a disease of the left atrium, but not always. And so it is important to recognize that there can be both together. And the mitral leaflets also can be diseased in a way that normally with the secondary MR, the mitral leaflets elongate, and sometimes they do not elongate adequately. And so this is the reason, because this is a living tissue. So there is remodeling of the mitral leaflet. Importantly, if you look at the anatomy of the mitral valve, there are 2-3 things that are important in this thing. One is that the mitral valve is attached to the atrial muscles, not to the ventricular muscles. It's an annulus, but the valve is like this. So when the annulus increases in size or goes further, you will see that there is with the atrial enlargement, the mitral valve leaflet is restricted in the atrium, the posterior leaflet. Also, very importantly, there is an annular motion that contributes to the systole. So there is an anterior-posterior contraction, height, and even the motion during systole. So these are very important informations to keep in mind that the annulus contributes, especially in the patients who do not have, impaired ventricular function. The annular function is very important, and this can be measured nowadays with tissue Doppler. So the functional MR, as I said, is a common thing that happens. This is a good paper from Mayo Clinic to say that how many people really undergo procedure or not. So it can be ischemic, atrial fibrillation related, and it is very important that only 4% of the people in the lifetime are having surgery for this. So this is not a common thing. So either it's FMR with ventricle, LV remodeling, or FMR with atrial. Of course, can be both. It is very rare. Atrial MR more commonly happens in older people. And here you can see atrial MR, ventricular MR does the worst, atrial MR slightly better, and OMR. This is mostly done with no treatment or medical treatment. If you look at a patient, this is a classic patient with an ejection fraction of 25% prior surgery, now coming in with mitral regurgitation, as you see here. And this is a typical mitral regurgitation that can be analyzed. I'm sorry, let me just restart my computer. I know it's coming up. So you can see here that the mitral valve is not coapting on the medial side. So this is a common thing with the ischemic cardiomyopathy, that it does not coapt on the medial side. Uh, yeah, 1 second, because I think this is what happens with the computer with too many images. Give me 1 second. I'm sorry about that. I will reshare it. One more second. So again, the imaging is super important to one more second. Basic. Okay, I hope you can see it now again. So here you can see that the medial side is not coapting. Here on the ventricular side, the medial side is not coapting. And so this kind of patients with the mitral regurgitation are very well treated with edge-to-edge repair. And currently for the functional mitral regurgitation, only MitraClip is approved. So there are 2 trials, 4 trials, but 2 trials to begin with. This was the COAP trial we did and the MITRA-FR trial. And as you know, that the COAP trial was positive for both the heart failure readmission as well as for the mortality. And it was a very strongly positive trial. There is still a residual mortality, but it's a strongly positive trial. And the MITRA-FR trial, supposedly in the similar kind of patient population, was negative, half the size. The MITRA-FR was half the size of the COAP trial, but there was no real uh, benefit. So why was that? So this is my understanding that if you have a patient with mitral regurgitation and heart failure, it's very hard to tell which is the cause of the symptoms. So if you look at the severity of MR, LA function, and LV functions, 3 things are important to understand. So if people have severe MR, but not that much of LA dysfunction or LV dysfunction, so like inferior wall MI, where the posterior leaflet is restricted and is leaking, this is the best patient. So this patient, if you treat the mitral regurgitation, they'll do amazingly well. But these are not the common patients. So common patients are here where there is a LV dysfunction, there is some LA dysfunction and some mitral regurgitation. So this group of people still did very well in the COAP trial. If you take the patients who have severe LV dysfunction, severe LA dilatation, but not that much MR, then obviously their prognosis is determined by the LA and LV dysfunction and not so much by MR. So if this patient can benefit from the clip as much as this patient would is a question. Does not mean that we deny the therapy to these patients, but the expectations would be to have less benefit in this particular group of patients. If you look at that particular patient that I just showed you, we put 2 clips side by side. And again, fluoroscopy is very helpful as well as, and again, the patient has BIV, ICD, all those things, a good medical therapy. And despite that, if there is symptoms, then a edge-to-edge repair is a good idea. And again, looking at what happens to these patients with correction of the mitral regurgitations, the LA pressure comes down, but just recognize that they still have a high LV and diastolic pressure. So the LV and diastolic pressure is 20 plus. So these patients have a LV dysfunction that is the cause of many of the problems. And there was a question raised whether really you decrease the size of the LV or not. In the COAP trial, we did not see LV remodeling, but at least there was no tertiary MR, meaning that the LV did not remodel in the wrong way and did not cause any further dilatation of the LV. So at least the systolic volume and the diastolic volume stabilize over time. Ejection fraction typically does not increase, but does not decrease. If you look at the indications for surgery in the secondary MR, in the FMR, it used to be called, now it's called secondary MR, is all class 2B indication with evidence C, meaning that there is not much randomized information, and this is a class 2B indication. There is one trial that was recently done, which is called the Metacon trial, which was published in New England Journal last year. They enrolled over almost 80 years, a fairly small number of patients. And what the idea was that it would be EF more than 20 would be randomized to surgery or mitral clip. But it ended up that to be a surgical candidate, that EF had to be good. So patients had 45% average EF, and they were then randomized to a mitral clip or surgery. So it's a small trial with 200 patients, 100 in each group, as you see here, 70-year-olds, so not that high risk. And as I said, the mitral regurgitation was either from annular dilatation or ventricular tethering, but EF was well preserved, relatively well preserved. So in the COAP trial and in the reshape, I'll show you, the EF is about 30%, whereas in this trial it's 45%. And very importantly, it showed very clearly that the safety of the intervention was outstanding. Efficacy was also very good. So if you say that how the interventional group is at the top, the event-free survival was amazingly better in the interventional group. Not amazingly, but expectedly better compared to surgical group, because there were so many different kinds of complications that happen in these patients over time. And as you can see here, these are including stroke to new onset atrial fibrillation, which was 30% versus 3%. And the stroke was also 0 versus 4.4%. So this just trials, the importance of this particular trial is to say that if this is the only real comparison with the surgery, and at least the effectiveness, in the sense that if you look at the severity of MR reduction, NYHA class reduction, was very comparable to surgery with much less complications that you see. So it's a small study, no medical arm, is safe and effective, at least in the patients with mildly reduced EF who are surgical candidates. So this is something, a step forward, at least for some randomized data, to understand that this therapy works for these patients. The Reshape 2 was also published last year, so it's worth noticing. It was a trial that the idea was to have moderate MR in this particular trial, and the endpoints were very similar to the COAPT. It also took a long time to enroll, and the trial is 500 patients. So, compared to COAPT, 600, 500, so good number of patients. And as I said, that there was ejection fraction was about 30%. In this group of patients with comorbid patients. And the results, in my opinion, are very, very similar to the COAP trial, in the sense that the primary composite endpoint with the death and rehospitalization was reduced. However, if you look at just the death were not reduced as they were reduced in the COAP trial, probably because the patients were not so high risk. But otherwise, the KCCQ, everything was favorable compared to medical therapy alone. And therapy was effective. 90% of the people had less than 2, either 2+ or less than 2+ mitral regurgitation, and 74% were in NYHA class 1 and 2. So if you look at as I said, the death was statistically not different, 22 versus 29.9 from any cause, and cardiovascular cause was not different. Again, this is mostly driven by the fact that these patients were probably not as high risk. There is also another explanation to say that these Reshape 2 patients This is Milton Packer's idea to say that you compare the LV and diastolic volume to EROA. Similar concept to say that how chronic is mitral regurgitation that is causing LV dilatation, and how severe is the mitral regurgitation. Meaning that if your LV is dilated but mitral regurgitation is not that bad, then treating the mitral regurgitation alone is not going to solve the problems. This is what I was explaining in MITRA-FR, similar concept. So this just shows you the relative size of the ventricle, EROA, and what were the benefits. And as you can see, the reshape 2 was a slightly different patient population compared to QUAD. Now, what happens if you are not really a good candidate for clipping? So this is the patient where there is a coaptation from the lateral to the medial commissure is not good, and the valve is leaking in the whole coaptation line. You could try to put a tear, but it is possible that you will not have a very, very good result with this particular patient. So there are several different trials ongoing. So this is the M3 where you can put a dock around the mitral valve, and then you can put a valve inside of the dock. So this is once the dock is deployed, you put like a mitral valve in valve or mitral valve in a ring. You put a M3 valve, which is basically a SAPIEN 3 valve, but it's covered. So this particular strategy is working, and you will see some more data coming out of this particular trial. It is a single arm study, so we will know the safety of the procedure is amazing. So this is something to keep in mind that patients, and here you can see that there was very severe mitral regurgitation, and now with the M3 valve, this is the dock, and there is no mitral regurgitation. There are several other valves being evaluated, so this is not the only valve. But one thing to understand that when you put a valve in the annulus is frozen, and that's also true for the tricuspid valve. So many times you do not see the annular motion, and so the LV function suffers. So this is just an idea that the annular motion causes about 10% of the EF. So contrary to the MitraClip, where you do not freeze the annulus, MitraClip people do very well, even if there is no mitral regurgitation with severe LV dysfunction. Whereas with the valve replacement, that is not usually the case. There's another device that is available, which is a Carillon device that you put it inside of the coronary sinus and splint separate the mitral annulus from the left atrium. So as you see that if this is the way that it is atriogenic AR or ventricular AR, so we can pull the left atrium because the coronary sinus is on the left atrial side, and that decreases the mitral regurgitation and also remodels. So we are doing a randomized trial, which is called Empower trial. I'm the PI, so that's why I'm bringing it up. Simple trial, 10 French catheter from the IJ. And we are doing it for any degree of MR, 1+, 2+, 3+, 4+, with a dilated ventricle and symptomatic patients. We have enrolled about 90 patients out of these 300 patients. And these are the hierarchical endpoints that I've listed. And so Empower trial is currently enrolling. I want to just cover in the next 10 minutes or so the tricuspid regurgitation. Primary, secondary, similar to mitral valve. We did the first, I just have to say that because we did the first tricuspid valve replacement in the world percutaneously. This was a valve that was developed at Cleveland Clinic by Dr. Jose Navia. I was also helping. So this particular valve is no longer available. But the idea was that we could replace the valve. This is the first picture when we were doing the tricuspid valve replacement, and it was successful. Most important thing to understand in this picture is the size of this valve. So this is the valve, and I'll try to go to the end of it. So look at the aortic valve and look at the tricuspid valve. So this is the size of the aortic valve. This is the size of the tricuspid valve. So it's huge. So to put it in the right position, right place is one thing. And second is that it eliminates the annular function because it's so big in the annulus to anchor it. So this is something to keep in mind. And there's several new devices in the tricuspid area, including different valves. But as you know, the two things got approved this year by the FDA: the Evoque and the TriClip. Both of them had a breakthrough device exemption, so the relative data are less, and FDA is requiring to collect more data on these particular devices. And they are so the Evoque valve, as you probably know, has anchors. There's a roughly 29 millimeter valve inside. It's a bovine pericardial valve. Very simple delivery system, and you anchor it in the right place and then deploy it. Currently, it's available commercially. So we are doing a fair number of these valve replacements. And as you can see here, the valve, but this is a one-way street. Once the valve is open, you cannot really take it out of the patient. Uh, uh, Sorry about that again. For some reason, it's frozen. Sorry about that. So one more time. I know that I have 5 more minutes, 3 more minutes, so that we can take question answers. But I want to just very briefly summarize the data for the tricuspid valve. I'm almost there. Stand by. Does this, but yeah, I hope you can see it. So this is the Evoque valve that we are deploying. I think there are too many videos on this computer, so that's why it's doing that. And you can see that the valve is very big and it's competent. There's so many different sizes, but remember, it's 56 millimeter valve is available. 56, so huge. Remember that the typical valves are, anywhere from 20 to 25 millimeters. So this is 56 millimeter. So this cage, the inside valve is 29. So this is the TriScent trial. So TriScent trial was completed. TriScent 2 was published in New England Journal, and it was the Evoque versus optimal medical therapy. And importantly, if you look at this, the KCCQ was improved, NYHA class was improved, 6-minute walk was improved. But if you look at the hard outcomes like hospital admission or death, they were not that different. So all-cause mortality, as you can see, Evoque versus optimal medical therapy, 15 versus 12%, and tricuspid interventions, not that important, but heart failure admission 10 versus 12%. So no difference in the all-cause mortality or heart failure admission, but definite improvement in the KCCQ, NYHA class, and 6-minute walk. And of course, the TR gets better. So TR improves, KCCQ improves related to the TR. Complications were not trivial. So there is severe bleeding, there is valve replacement, death, arrhythmias, conduction abnormalities, and especially the need for permanent pacemaker was anywhere from 12 to 15%. So this is something to keep in mind, that this is an important part, and it can be done in the patients with permanent pacemaker. So this is also important to keep in mind. This is the device, the TriClip, and in the TriLuminate trial that was also published in New England Journal a year before, again, 350 patients, 78 years of age, severe TR. And if you look at this again, the TR was reduced but not totally gone. So it went from severe, torrential. These are the new terms, massive, to moderate or severe. And if you look at the KCCQ, that was the main difference. So the only difference again was KCCQ. Uh, the important thing was that there was a graded response in the sense that since it is not a blinded sham controlled trial, uh, how can you trust the KCCQ? The only way to trust it is that it correlated with the TR severity. So at least there is some uh, correlation with the TR severity. Again, this is done fairly simply. So you can put the tricuspid clip. Uh, and this is an important message. The tri-score, this is a score that was created to say that if you have low score, intermediate, or high score people don't do well with either surgery or transcatheter therapies. And the important things is that how much diuretics you're using, what kind of renal function you have, and what is the liver function. So these are the important things that determines this particular score. So it's something to know, and how you apply this knowledge is to say that if the tri-score is moderate or severe, then conservative management may not be unreasonable. Other corollary of this is that you should refer the patients with the tricuspid valve earlier rather than later. How do we treat them medically? Not that different, but now the SGLT2 inhibitors can be used, and also the aldactone can be, or spironolactone can be used, and diuretics can be used. Uh, there are a lot of different ways that we select the TTR versus TTVR versus trick valve, and I think it is important to recognize that how we measure the RV function is very important, and all these different measures are something to keep in mind. I put a one diagram to say that if people do not have a high gap, then these days we do clip, and if they have a very large gap, more than 10 millimeters or 8.5 millimeters, then doing valve replacement is a better choice. But many of these patients are still excluded from this. And so what is the other option? So the other option is to do a trick valve where you put a valve in the superior inferior vena cava. So this is a prepackaged valve, very easy to do. We did the first one in, I think, long time ago, at least a couple of years ago. And it's done with conscious sedation. As you can see that we are putting a valve in the superior vena cava here and inferior vena cava. And we are now, this trick valve had a initial Euro CE mark study completed. It's available in Europe. And we are now doing it in the United States. Dr. Rishi Puri and myself are the PI, and we are doing this trial currently in the feasibility phase, and then it will be in the pivotal phase. So I want to summarize to say that the tricuspid regurgitation therapies are also rapidly evolving. They are now available. You should refer them early because as the trick score increases, it's a futility. Multimodality imaging is very important. And as you saw, the computer breaks because there's so many images. And the heart valves, heart team assessment is very important. So it's a bright future. As I always say, that you have to be cautious but courageous. And I like this statement from the Prime Minister of India, first Prime Minister, saying the policy of being too cautious is the greatest risk of all. So thank you again for your attention. And I leave this slide up for the CME credit for you to apply. I think I was on time to have some questions.
I'm going to jump in quickly and talk a little bit about the tricuspid valve repair relative to left heart function. In other words, are there patients with biventricular failure in whom closing the valve or fixing the valve actually makes them worse? What's the thinking about that kind of situation?
Right. So for the tricuspid valve clip or mitral valve clip, if you put, so this is a little different than what we learned in the beginning, that saying that if you increase the afterload, are you going to make the ventricles worse? Right. That is the question that you are trying to ask. It is true that when you increase the afterload, the ventricle does become worse, especially if we replace the mitral valve or tricuspid valve. However, when we do the clipping or the tear procedure, edge-to-edge repair, it is not true that we see that. And the reason, there are two reasons. One is that maybe we are not eliminating all the mitral or tricuspid regurgitation. And the second is that I think, in my opinion, the reason is that we are not freezing the annulus, meaning that we are keeping the annular function available for the diseased ventricle, which is super important to have some contractility. So it is not so much the afterload reduction, afterload increase, but also the annular freezing that is causing the problem, and also the pacemaker rate. So when you replace these valves, there is increased risk of pacemaker that also hurts the patient. Whereas with the edge-to-edge repair, you don't have that problem. So people who have really bad ventricles, if we can do edge-to-edge repair, I think it's much safer than doing a valve replacement. And that's what we do currently, that we use edge-to-edge repair for this patient. Technically more difficult because obviously, you have to, it is a little bit of an art along with science to repair the mitral valve.
Thank you very much. This was an outstanding summary of really amazing technology and science. Swetha.
Thank you so much, Dr. Kapadia. That was an excellent talk. At this time, we can open up the chat and open up the floor for any questions from the audience. I have a few of my own, but I will open it up to the audience first before I jump in. So please feel free to add your questions to the chat box, and then we can ask them in order.
I also had a question for you to say that as practitioners, how do you feel that how these percutaneous therapies of mitral and tricuspid valve, in your perspective, are changing how you manage the patients? Is it something that is still something experimental, or something that you feel that is not a main treatment, or is it something that you feel that it is available and should be assessed for a large number of patients? Maybe Shweta, you can answer that, from a resident or fellow standpoint.
So sorry, Dr. Kapadia. I was trying a little hard to hear that. For some reason, my connection just cut out a little bit. Would you mind?
No worries. No, what I was saying is that is this a reality for the residents and fellows and the general cardiologists, that the mitral and tricuspid valve therapies are available, or they still feel that this is an experimental procedure and should be reserved for some small group of patients?
Yes, thank you so much for opening up the floor to that question. So I actually have a very strong personal interest in imaging, and especially TEEs, and more recently have started to read more about the structural cardiology structural intervention guidelines. So something that I find very fascinating is sort of, the developing sort of devices coming up for tricuspid valve interventions, because we do have a lot of patients kind of suffering from what Dr. Vetrovec mentioned, biventricular failure sometimes, just RV failure. So I've certainly been reading more about the advances on that side of things. And I think we're, of course, a little bit spoiled being in an academic institution with access to structural interventions, but certainly, we've seen quite a few of them done. I know our cath lab here at VCU is very prolific, and especially doing mitral clips. But I think what I appreciate is kind of the very thorough screening process that our patients kind of undergo before they become, before they are considered, or before they do undergo mitral clips. And I think that really improves the safety profile. But ultimately, I've seen these cases assisted with some of the TEE imaging at times. And these patients have great outcomes. And it's been kind of fascinating to see just, how quickly they feel better in a lot of cases. It's really been fascinating to me to see also the literature kind of come up on the tricuspid valve side as well, for sure.
No, thank you.
And Dr. Kapadia, if you don't mind, I actually have a question for you as well, if you have a moment.
Of
So
course.
I know, again, as I mentioned, I've been reading more about tricuspid valve interventions. And I'm just curious. I've been reading about some patients having conduction system disease after tricuspid valve interventions. I'm assuming because of how, I guess, closely the leaflets sit to the triangle of Koch. And I'm wondering, in your practice or kind of in your experience, have you seen that often as a complication?
Right. So yes. So currently, with the, of course, with the edge-to-edge repair, there is no increased risk of pacemakers. So when you are just doing leaflet modification, there is nothing is happening. But if you replace the tricuspid valve, there is clearly a risk for, and that risk, as I said, can be anywhere from 12-15%, depending on the patients, uh, of complete heart block because of the proximity of the AV node. So what surgeons had done in the past is to put the ring where they don't sew. The ring is an open ring, a tricuspid ring, if you have seen. It does not They don't sew it on the medial side where the trigone is so that they don't get the AV node. We cannot do that in the percutaneous intervention. So many times, uh, this is a challenge. So we first of all have to have an EP person involved in the tricuspid valve intervention. The second is that we are using right now a coronary sinus lead when they develop a AV block, and this sometimes helps these patients to do a so rather than putting it through the new valve, we can do a coronary sinus lead, and that sometimes can help. Uh, it it decreases the chance of doing a left bundle pacing, for example. So this is something also to keep in mind. And leadless pacemakers, we have done it through the newly deployed tricuspid valve, or we have removed the leads, put the leadless pacemaker first, and then done the tricuspid valve. So all of these things are possible. But again, working with the electrophysiologist is super important on the tricuspid side.
Thank you so much. There are no other questions. I have one more.
Just
Very.
just a comment from General. Your original question about these technologies are incredible, and it was a wonderful presentation. But I think we recognize the importance of these interventions too late, especially in tricuspid diseases and in the primary mitral regurgitation. So it was I think the whole message is that we, as general cardiology, should be addressing them much sooner than end stage. But thank you. It was a really incredible talk. Thank you.
No, and I that's why I asked the question, because I think one important message is that, as you rightly pointed out, that these technologies are available, safe, and they really don't have a lot of penalties. The only bad part is that if the disease is very progressed and end stage, then they don't help. So we have to strike the balance. I'm not saying that all moderate mitral regurgitation you put clips, but at the same time we have to strike the balance. So a good doctor is super important. That sees the patient repeatedly. If patients are going in the wrong direction, this is the time to pull the trigger. And so, as I commonly say, that if the treating mitral regurgitation or tricuspid regurgitation is an art, and you have to know the patients well. It's not just the technical side. Technical side is, to be honest, relatively easy, but to try to decide when to intervene and what is the right time. So I always tell people, please send patients. I will keep following them. I don't mind following them to say that what is the right time to do it. We are learning ourselves. There's no right or wrong answer, but earlier most likely is going to be better. Thank you again for the opportunity, and I really enjoyed it interacting with everybody. So
great job, Samir. Thank you very much.
Pleasure. So nice to see you, and keep up the good work.
Thank you.
Thank you.
That wraps up Grand Rounds for this morning. It's just about 8:30. Thank you, everybody, for joining.
Yeah.
Thank you so much.
Great job, Samir.
Thank you. Bye-bye.
Bye-bye.
Bye. Thank you, Dr. Vetrovec.
Thank you.